Poa sana. Rudisha hiyo kitu pale umetoa. Nitachapa na hujaoga. Mbona hujaoga? Uangalie hiyo kitu isi nini? Isikue uji. Nini?
Wanadai kwamba aliwaada mzozano na Joy Makena, jambo ambalo lilisababisha yeye kusoba kila yake na kumpiga risasi mbaya.
Ona kwenye umerusha pale. Wewe ndio hujaoga. Ukuta nguo uoge. Ui.
ametafutwa na polisi mchana wote kuhusiana na kisa ambapo mwanamke mmoja amepigwa risasi katika mvutano uliomhusisha mwanasiasa huyo kule Nanyuki. Inaarifiwa amejisalimisha kwenye kituo cha polisi cha Nanyuki mjini na hivi sasa ngali katika afisi zake OCPD kwa pale Nanyuki. Polisi wanadai kwamba mwanamke huyo kwa jina Joy Makena mwenye umri wa miaka 32 uliotokea kwenye uwanja wa Kanu kule Nanyuki, kaunti ya Laikipia. Polisi wanasema wamepata habari kutoka kwa wananchi kwamba mwanamke huyo Makena amepigwa risasi mguuni wakati.
Good evening. Good. Good evening. Good evening.
Good evening.
Thank you for your response. Swaleh, who's Dr. Swaleh is an obstetrician and gynecologist working at Mombasa. She'll talk more about herself. I know we had her. So sorry for that technical glitch. So today we'll be having our speaker Swaleh will be taking us through postpartum care, and I know we'll enjoy the session. So thank you all for joining and welcome, Dr. Lee.
Thank you very much, Katile. I hope you have all been fine. I would request that we kindly mute ourselves. It's a very quick session. It's a Sunday evening and we'll be done in a short while. Now, I will not be projecting because postnatal care is pretty straightforward. And so I really don't think we need slides for that. It's a discussion, basically. What is postpartum care? What is postnatal care? Just breaking it down, I feel like it would be better understood if we just sort of chatted, okay? So my name is Dr. Swaleh, and I am a gynecologist based in Mombasa, to be specific, Premier Hospital. I am very much interested in fertility, but again, you're not just an obstetrician gynecologist, you practice both. You don't just practice gynecology, you practice obstetrics as well. And maybe to kick us off, I'll start with the definitions and what is postpartum care and what is the postnatal period, what is the prepartum period. So by definitions, postnatal period or the postpartum period or the prepartum as we know it is a period beginning from the delivery of a baby, delivery of the placenta, up to 6 weeks. Now, I say 6 weeks very loosely because there has been a contention in how soon does it end? When does it end? When does prepartum end? Is it really 6 weeks? Is it a black and white 6 weeks? Or it can be modified as per woman. So some school of thought think it should be taken to 8 weeks. Other people even think it should be taken up to 12 months. And so it's out there, but strictly speaking, usually up to 42 days post-delivery. Kama vile Waswahili wanavyosema, siku zako 40. Siku zako 40 sort of inaambatana na wiki 6 baada ya kujifungua. Okay? Good. So what then is postnatal care? not period, but care. So this is care given during the postnatal period to both the mother and the baby, okay? And to ensure that both of them are healthy, capable of, surviving, that the mother is capable of taking care of a newborn, and that she's equipped with all the information that she requires for that specific period of time. So not only do we manage medical issues, we also address psychological concerns. We also address cultural issues surrounding childbirth and delivery. I'll give an example of this. There are some tribes that probably advise that, hata kabla mwanamke hajakauka, before she dries up the lochia, she's already sexually active. So those are the things that we need to address as healthcare providers, so that we sort of abide with the culture, but at the same time also provide quality care to the woman, make sure that she's healthy. Okay, good. So what is the relationship then between postnatal, postpartum, and puerperium? And so the three terms mean almost the same period, but postpartum and puerperium, to be specific, refer in regards to the mother. Postpartum, after delivery; puerperium, period after delivery. But postnatal is specific to the baby. And so we use these words interchangeably because it is assumed that we are taking care of both the mother and the baby, okay? And so I will start with infant care because most of the time it is overlooked. Usually we think postnatal, we think postpartum, we think the woman. So let me start with the infant care so that what exactly is a baby entitled to from the time the baby is born to the time the baby is probably out of our radar as obstetrician. What exactly is that baby entitled to? And so I'll break it down in terms of timelines. So within the first 1 hour, you want the mother and the baby to, interact skin to skin. Usually we say immediately the mother delivers, even before you clamp the cord, put the baby on the mother's chest, let the baby have that time with the mother, let delayed cord clamping take place so that we can ensure maximum benefits to the baby. Of course, this is where it is indicated. Where it is contraindicated, for example, the baby is in distress, then there is no point practicing delayed cord clamping. Why do we encourage skin to skin? Hypothermia. The mother's temperature is perfect for the baby. And so this ensures that optimum temperature to the baby, you don't have to regulate anything, is usually offered to the baby. In the first 30 minutes, okay, to around 6 hours, usually we want to initiate breastfeeding. In the first 24 hours, we want to ensure that this baby has gotten the immunization. And here I'm referring to BCG, polio, okay, the very first set of immunizations that are usually given. Also, within 24 hours, some places would encourage a birth, especially if there were situations surrounding the birth, like chorioamnionitis and all that. So let the baby have the first birth. Of course, the water should be optimum temperature, and also the registration of the baby. We keep forgetting this, and this is usually done in haste after, or rather during discharge. So in that 24 hours, make sure that the baby is okay, the book is written, the baby's details are notified, the notification is out, so that if it was a normal vaginal delivery in the first, after 24 hours, the mother is ready for discharge, then the baby can go home. Nothing has been left out. Within the first day and the third day, usually you want to review that baby again. This time you're reviewing for specific things like bleeding of a cord, like jaundice, things that may come up later, but not exactly at birth. In the first 6 weeks, okay, you want to follow up this baby. And in the sixth week, you want to ensure that the baby has gotten the first batch of immunization following the 0-hour immunization. Between 6 and 14 weeks, that means 6, 10, and 14 weeks, again, immunizations, weight taking, making sure that the baby is very well catered for, making sure that everything is okay baby-wise. And by 6 months, by this time, we're talking about now the following immunizations and also introduction of weaning. So there's a lot happening from the very first hour to the very first 6 months of life. And this is where we usually pay attention, especially as obstetricians, until the first 6 weeks. When we give the baby the first, or rather the second doses of immunization, then we can safely say that the baby is now out of our care and handed over to the pediatrician, okay? So in the mother, what exactly are you looking for, especially in the first to sixth hour? You're looking at the vitals, you're looking at the temperature, you're looking at the blood pressure, you're looking at the pulse. And this I cannot stress enough, because it's the simple things that will alert you to, like danger signs. For example, if the BP keeps coming down and the pulse keeps going up, then okay, there is a form of hemorrhage going on. The temperature, what if it goes up? What if it goes low? Okay, so those are the things you're looking out for. So you're also looking, other than the vitals, you're looking at the uterus. Is it contracting as it should be? You want it well contracted, hard as a rock. And so you're looking out for features of anatomic uterus. These usually feel like a boggy mass, and the uterus is not exactly well contracted. You can palpate it at 20 or even above 20 weeks of gestation. So usually you want it below around 16 weeks going down. You want to look at her vaginal bleeding. So if the woman had a vaginal delivery, you want to look at how much blood is being lost. How much do we expect? Is she a twin delivery? Is she a singleton delivery? If it was a cesarean delivery, you want to look at the incision. How is the blood also, her vaginal bleeding after cesarean? Because the uterus will also be atonic, okay? You also want to be on the lookout for internal hemorrhage. We have had cases where a woman goes on to have a vaginal delivery, a cesarean delivery, and then an internal rupture, uterus rupture is missed, especially in vaginal delivery. You could struggle with a woman and deliver, and you think you're out of danger and you're home and dry. And then later to realize that in the process of pushing, she actually ruptured. So those are the things that you want to look out for. How then will you pick out internal hemorrhage or uterine rupture or any other causes of internal hemorrhage? The vitals. The vitals will be your first sign of that something is not right. The blood pressure will go low, the pulse will go high, the temperature sometimes may drop, the examination of mucosal surfaces, the conjunctiva, the tongue, they'll all be pale. So those are the telltale signs that, okay, something could be happening inside. You want to palpate the bladder, especially in regards to uterine atony. You do not want the bladder to be so full such that the uterus cannot involute. So you want to keep encouraging the woman. Are you able to pee? Are you able to walk to go and pee? If it is a cesarean patient, is there a catheter so that the bladder can drain? Sometimes a woman may deliver vaginally and then have some sort of inability to void, in that she can't pee. Maybe if it was a difficult delivery, if there's edema around around the urethra, so she may not be able to quite pee. So such a woman, you may want to probably pass a catheter, release the urine so that the bladder is not so distended. You want to look at signs for dyspnea or maybe pleuritic pain, chest pains. We know there is such a thing as pulmonary emboli, amniotic fluid emboli. Actually, if I'm to give an experience, one time, a colleague of mine, it's actually my husband who's on an intern, he delivered a woman and she pushed, and like the way there's the half and puff and people are cheering, push, push, push. And then she pushed. And then once the baby was out, the woman collapsed backwards and started frothing. And so immediately that already alerted them that, something is happening. It was an amniotic fluid emboli. So sometimes they're a bit fatal. You may not save a woman. Sometimes you may. So it's always good to catch it. I think that traumatized him. Didn't do obstetrics after that. He went and did things. But yes, such things are usually very important to catch early on, okay? You want to look at the perineal area. You want to look at the vagina. You want to look at the vulva. I have seen cases where, a woman did not have a cervical tear, a woman did not have a uterine rupture, but had a vulval hematoma where a tear on the vulva, and the vulva can expand and hold so much blood such that that woman can actually sort of bleed out. So you also want to be on the lookout. Are there lacerations? Are they bleeding? Is there edema? Is there hematoma forming around the vulval area? Okay. You also want to assess for pain. I know there is a normal contraction of the uterus, which causes a bit of, crampy pain, but the pain should not be excessive as in uterine rupture, okay? So maybe choriomyelitis as well. So you may want to look out for that. Is the woman in pain? What exactly is going on? And probably pick up a few things as they happen in real time. Adverse drug effects, and this especially for a woman who's coming out of theater. You've used a myriad of drugs. You've put her under, if she was under general anesthesia, you've put her under spinal. So you want to see all these drugs that are administered to her. Do they have an effect on her? Are they lingering, these effects? Sometimes also misoprostol that is usually routinely given to prevent postpartum hemorrhage. You may want to see, okay, what are the side effects of this misoprostol? I know many women usually have the shivering episodes, okay, you're feeling very cold. So you may want to see how bad are these side effects, reassure the woman, take care of really bad side effects. You may also, in the first 24 hours, now in regards to the mother, encourage rooming in. And I hope you remember that WHO and UNICEF have the baby-friendly hospital initiative, if I remember it correctly. And this is just a venture that seeks to introduce the baby to the mother and the mother to the baby as early as possible, as soon as birth. But within 24 hours, that baby should have been roomed into the mother. So this encourages bonding. This puts away things like postpartum depression. This makes sure that the baby is latched on quite early. This makes sure that basically, mother and baby have been introduced to each other, if I can put it as simply as that, okay? Within 3 to 6 days, you will also may want to assess things like temperature, for example, late onset sepsis, as in the case of, say, choriomyelitis again, okay? So there's a woman who naturally was under risk of, say, forming postpartum sepsis. So it may not show itself in the first 24 hours, but within 3 days, it may show itself, okay? So you may want to also assess the lochia. What is a lochia? The pervaginal bleeding that is usually seen after delivery. And so we know that the lochia should no longer be heavy. It should have tapered off, not necessarily being dry. 3 days, you're still having lochia, but it should not be smelly. It should not be so heavy. It should not be clot-filled. It should be a normal red color, okay? You may want to reassess the breasts. If latching occurred, are you exactly breastfeeding correctly? Are we starting to form nipple cracks? Are we starting to form engorgement? Are we starting to get mastitis? You may want to assess the woman's mood. And I usually emphasize on this. No woman comes to my clinic without me talking about, we call it A or B, but it's actually not any other business. It is actually the main business. How are you? How are you dealing with this baby? How are you sleeping? Where is your support system? Do you have a support system? Okay, in the event that you should crash, in the event that you should tire, who is there to help you? Who is there to catch you? So you're basically assessing mood. And mood, I'd like to remind you that it is a spectrum. There is a woman who's just slightly overwhelmed to the woman who's actually considering infanticide, killing the baby. And so anywhere on that spectrum, and you're not fixated on any one point, a woman could see so on any point of that spectrum. So you may want to keep a keen eye and see, okay, fine, I know this baby is new, this baby is an added responsibility, and we cope, but how is she coping? Is she stepping up, or things are overwhelming to her? Is she totally overwhelmed, no support system? And is she actually bordering on depression, psychosis, etc.? Okay, by 6 weeks, usually we expect that the uterus has finally settled back in its pre-pregnancy state, and you're assessing basically recovery. If it was a Caesarean, how is the incision? If it was a normal delivery, if there was a tear, episiotomy, how is the healing? Assess for anemia, assess for contraception use, okay? And by 6 months, generally, this woman should have a general health exam, assess contraception as well, and then also assess weaning. Now, let's bring it to the ground because this is just theory. How many visits then does a woman get after delivery? And where are these visits carried out? Are they carried out in the hospital, in her house? What exactly does the literature say? So, following antenatal, following delivery, we usually know that a woman is entitled to at least 4 postpartum visits. Usually the first one is within the first 6 hours of delivery. You're still within the hospital. The second visit ideally should happen between day 2, day 3, ikipita sana day 4. The third visit should occur at around 1 to 3 weeks, and the final visit occurs at around 6 to 8 weeks thereabouts. How I go about it? In the ward after delivery, there's a special place we keep you. You don't just go to the ward after delivery. You don't just go to the ward after cesarean section. There's a postpartum room where we monitor you closely in the first 6 hours. And so we assess all the things I've talked about. I will not repeat myself. But basically, you're there right under the midwife's nose, under the doctor's nose. And as things happen in real time, we catch them as they happen. So within 2 to 3 days, for those who had a cesarean section, usually they get to have this visit. Why? Because you're still within the hospital every morning. How are you? How was your night? How is the baby? Is the baby breastfeeding? How is the lochia? Is it smelly? How is the wound? Is it starting to heal? How is the pain level? Management of pain. So most of the time, the vaginal delivery is usually we discharge within 24 to 48 hours. And so if it is within 48 hours, then you get to have that final review before you go home. If you're lucky, 24 hours, hey, we hope that by 2 weeks, then you're still quite as fine. And by 1 to 3 weeks post-delivery, usually I insist on a visit and the woman comes to the hospital in my case. But WHO, World Health Organization, actually has 3 models. The first model is where this is a woman who delivered at home using a traditional birth attendant, and the healthcare workers, the community workers, go to her to offer the postpartum care. Then there's a woman who delivered in the hospital, and the woman comes to the doctor, comes to the healthcare worker in the hospital. And then there's a hybrid model where even though she delivered at home, that within the first 24 hours, within 3 days, within 2 weeks, and within 6 weeks, the healthcare workers go to her. So wait, she may have delivered at home, but she comes to the hospital. So it can be a hybrid in that you deliver at home, but you're seen in the hospital, or you deliver in the hospital, but because of maybe distance or whatever, you can be seen at home on who is nearest you, where can you get the nearest care. At 2 weeks visit, other than the normal things, I'm assessing vitals, lochia, wounds, incision, episiotomy, the uterus, baby latching, breasts, etc. I will also start the conversation on what? Family planning. This is now my way of doing it. Actually, the family planning conversation starts way before delivery. As we finish up on your antenatal, best be sure that I will introduce the family planning contraception, because we know that there has to be a delayed period where you allow for one child to totally, get the maximum benefits from you, let your body recover before you can get pregnant again. So I usually bring up this conversation very strongly at around 2 weeks. We talk about it, we talk about all the side effects, we talk about all the methods, we tailor these methods, and I will not repeat myself because I'm the same person who presented postnatal contraception. So I'm assuming we are all up to date on that. So we tailor these methods to you, we customize them to you, and I give you enough time. So between 2 weeks and the final 6 weeks visit, that's 4 weeks. 4 weeks is enough time for you to go discuss with your partner, go do your research, go ukajipange kihela kama uko private facility. If you're in the government, just probably make your choices. So that finally, when you come in at 6 weeks, it is just a matter of implementation. I would like that by the time I'm releasing you to the world, you're out of my care by 6 to 8 weeks, that I am fully assured you're not going to come back after 3 months pregnant again. And so most of the time, usually the question will be, how ready do you feel to engage sexually again? And so if the answer is at 6 weeks already, then we should have a family planning method. There are those who linger. By 3 months, they're still not yet quite ready. And usually I say just before you engage, just make sure that you have a method in place. If I'm going too quickly, if there are any questions, just let me know in the chat box so that we can talk more about it, or I can slow down, okay? So what are the key findings, or rather the key issues that we may pick up during the postnatal period or the postpartum period? And then how do we go about them? Are they really issues to cause concern? If they are, how do we treat? Are they issues that are not really concerning, but then how do we reassure the mother? What exactly? Let's enter into the details of. And so we know that normally 20 to around 30% of women will have chills, and chills does not necessarily mean that you have an infection. Could be misoprostol, could be the effect of delivering. It takes a lot of actually calories and energy to deliver. So usually after delivery, a woman may be left a bit trembly and chilly. It may be because of fall of body temperature, okay? And so not all chills are bad. So if it is just kusikia baridi, you're having chills, we've given you misoprostol, warm blankets will do, keep the mother warm, keep the baby warm. If it is as a result of other things, for example, shock, please sort out the underlying issue, okay? Good. Sometimes also anesthesia will also cause chills. So you also have to understand why are the chills there and then now treat appropriately. Bleeding. So we know that a woman who has delivered definitely will be bleeding, okay? Whether Caesarean, whether vaginal delivery, it is just a matter of how much bleeding is usually expected. Number two, is the bleeding from out or is the bleeding inside? Internal bleeding is not normal, no matter how you look at it, okay? So if it is slight vaginal bleeding that usually we expect after delivery, reassure the mother, keep telling her to go void the urine, teach her how to do the fundal massage where she rubs the uterus fundus so that it can keep contracting, okay? If, for example, the uterus is not well contracted, you can come in with your drugs, you can bring in your misoprostol, you can bring in your oxytocin, okay? If the uterus is well contracted, maybe the bleeding is coming from tears, reassess again, cervical tears, all these things can be catastrophic, perineal tears, okay? So just make sure that you sort out the cause of bleeding, okay? Then, the vulva. So the vulva is not necessarily, most of the time, it does not cause issues, but you also have to be aware that if a woman has pushed out a baby, there are changes that will definitely occur in the vulva. It's a bit edematous, it's a bit swollen, it's a bit hyperemic, it's also a bit tender. So those are the changes that we expect. We do not expect hematomas, lacerations, bad tears, deep gashes, okay? And even as you examine sometimes, the fourchette, and the fourchette is the name given to the actual entrance to the vagina. Sometimes it may look intact, but beyond the entrance, inside the vagina, you could have tears. And so you have to be aware and constantly be cognizant that outside may be deceiving you, but inside there could be tears. So examine appropriately, okay? Good. And so you're also aware of the physiological changes that are taking place. So which changes are these, especially after birth? You're talking about the heart being a bit high, okay, where we have a bit of tachycardia. She's from exerting, she's from losing blood. And so the compensatory mechanism of the body is that the heart rate will be a little bit increased. As long as there's no heavy bleeding going on, then you're much okay with that. Pain. I already talked about pain. And so the pain here could come from several places. Remember, if she's from a cesarean, within 6 hours, maybe thereabouts, either she's awake or the spinal anesthesia has worn off, you may want to reassess pain, categorize it, maybe assign a value to it and give painkillers. The one who's delivered also should not be forgotten. Remember, everything is sewed down there. If she had a tear, you probably used lignocaine to repair, and now the lignocaine has started wearing off, the woman is in pain. So pain control is one of the most important pillars in postpartum. No woman should be in pain. There's no medal for bearing pain, okay? So give painkillers appropriately, do not hold back on them, make the woman comfortable. Sometimes it is good to reassure that the cramping nature of the uterus is normal. There's no amount of painkiller that may take that away. So once a woman is aware, then she's much more likely to be a bit more cooperative, a bit less panicky, okay? Good. What else? You're looking at the discharge and not now in terms of bleeding. Other than the bleeding, is there a purulent discharge? For example, this woman may have drained like 3 days before delivery. And so even as she's bleeding after delivery, there is a kafani smell down there, a purulent discharge, the formations of an abscess. So you may want to also have a look at that. Do you need to start antibiotics immediately? Is it just a matter of reassuring, or maybe just good hygiene? Because we know that some women may have labored at home, may not have showered for a while. So you need to clearly set apart these two events. Is it just hygiene? Is it an infection setting in? And sort it out appropriately. Urine retention is a big one. Remember, full bladder is one of the reasons of postpartum hemorrhage. And so you need to reassess. Is it a matter of she's unable to walk, to go and void? Is she unable to void? Like, for example, if there was neuronal damage during delivery, or is it just an ignorance where she doesn't know she's supposed to void, okay? So encourage voiding, pass a catheter, and basically keep the urine flowing, okay? Breast engorgement, especially by the 3rd day, and how does this present? This is a woman who did not have, say, breast milk before, and then suddenly the breasts feel painful, tender, and rock hard. And sometimes may even flatten out the nipples so that the baby is not able to latch well. How then do you go about it? Just probably express or remove the excess milk so that you have a nipple forming. I hope you understand what I mean by the nipple forming. You see, if the normal breast has a nipple coming out, and so once the breast is totally engorged, the nipple sort of is pulled back and is flattened. And so the baby can't latch on, and then that creates a vicious cycle, meaning you're already engorged, your baby cannot empty the breast for you, and so here you are getting extremely engorged. And we know that with engorgement, should the milk continue staying there with stasis of milk, you may form mastitis. So you may want to tell the woman, okay, use a warm compress, try and squeeze out the excess milk so that at least the breast is a bit loosish, the nipple forms, and the baby can breastfeed. If she has a pump, kindly pump out the milk, the baby can feed using bottle. And if at all, this is a woman, for example, who had an FSB, an MSB, lost the baby during delivery or before delivery. This is a woman who has delivered, does not have a baby to breastfeed, and breasts are now active. Then maybe this will be high time to sort of dry out the milk, kindly give bromocriptine, give cabergoline so that we do not have production of breast milk. If that is the case as well, we advise on very tight bras, cold compressions, try as much as possible not to keep pumping because the mind will perceive that the breast is being emptied and so we'll keep making more breast milk. So basically we are going now the opposite of what we usually tell normal women. Wear tight bras so that you don't produce a lot of milk. Do not pump it out so that the breast is not producing any more milk. And also use drugs so that they can dry out the milk supply. Okay, good. There are those women who may have come with hemorrhoids. We know that pregnancy predisposes you to hemorrhoids, constipation, and just the stasis of, things down there, okay? So she may have had hemorrhoids, but upon delivery, we now have thrombosis of the hemorrhoids, and we know that this is quite painful to deal with. Usually, if the stool softeners can't help, if the painkillers, amisol gel, glycerin, all those things, suppositories cannot help, quickly link up with the surgeon so that that can be addressed as well. You do not have to be in excess pain from the perineum, from the incision if it is a CS, and at the same time, hemorrhoids as well. I mean, how much suffering can a woman take, okay? And finally, we have those women who upon having a vaginal delivery, usually have spontaneous symphysiotomy. What is that? This is a separation of a symphysis pubis, okay, and the pelvis sort of opens up a little bit. Now, it's rare, and this happens when the baby probably was a bit too big for the mother to bear, okay? And most of the time, usually what we advise, it's not surgical per se. We may have a pelvic girdle. What is a pelvic girdle? It's like a corset, but for the pelvis. So that is sort of brings the two bones together. Kitambo, they used to say the woman should sleep on a sagging, like like a spring bed. The one that when you sleep in the middle, sort of dips you in the middle. So sort of the two bones are brought together by the sides of the bed, but that is no longer practiced. Kindly cover with adequate painkillers. It is a very painful thing to go through. And finally, link immediately to physiotherapy, okay? Good. There is also postpartum neuropathy. I forgot about it. And postpartum neuropathy is not necessarily because of, shearing or cutting off of the nerves. No. If, for example, you had a very big baby and as the baby was descending, most of the nerves were pressed, extended periods of lithotomy, like the way a woman is pushing and her legs are widespread. Sometimes with a shoulder dystocia, you also open up the pelvis totally, like the woman opens up the legs, like almost 180. So, well, it may have worked to deliver the baby, but that kind of position, especially sustained for a long period of time, may put like a stretching effect on the nerves, and the nerves get inflamed, sort of like a neuritis of sorts, a neuropathy, and you sort of have like, tingling sensation, inability to feel any sensation, inability to lift your leg. So all that will need physiotherapy. You need to give the nerves time to heal. And so for the neuritis to sort of go down, the inflammation to sort of go down, keep a very keen eye on it, because sometimes it may persist into a long-term problem. And my favorite, postpartum blues, postpartum depression. Now, there is a difference between postpartum blues. Postpartum blues is just that feeling of general being overwhelmed, not in a bad way, just being overwhelmed. I mean, it's a new baby, and more than 90% of women will be overwhelmed. You probably have other kids at home. This is a new baby. The baby is not sleeping. The baby is crying. You still haven't gotten your rhythm on how to breastfeed this baby. The baby is not latching well. You're learning each other. And so I usually tell my women, the first 2 weeks, do not expect a rosy transition. It is going to be hard work, because huyu mtoto hajawahi nyonya, huyu mtoto hakujui, huyu mtoto hajajua maisha nje. Like, you do not know anything about this baby, and the baby knows nothing about this life. And so you're learning each other. And so if there's a difficult period after delivery, usually it's the first 2 to 3 weeks after delivery. Now, there is a difference between a woman who's generally overwhelmed, not sleeping well, and a woman who's actually depressed. Depressed is where you lose desire to enjoy the small things, desire to live, desire for this child, just to lose interest absolutely whatsoever. And as I said before, it is a spectrum, and that could also go all the way to a woman who totally loses it. And there are women who are generally at risk more than others. Number one, if you already had depression before delivery, your chances of postpartum depression are almost quadrupled. Number two, if you lack a support system, here you are, you carried the pregnancy alone, you have no one, your mother is nowhere near you, your family, your partner left you, most likely, okay, you are at risk for postpartum depression. If you look at a woman who had other comorbidities, for example, your pregnancy was very difficult, you had this condition ongoing, another condition ongoing, ukaachishwa job, ukafanyishwa just, I know during this corona time, a lot of our women went through postpartum depression simply because many women were laid off. It was just a very confused time. And so there are a lot of comorbidities happening. So that also plays a role. I usually say, if it is postpartum blues, that can be, they're self-limiting. And so they can be, you can wait it out as a practitioner. Usually I say, from the woman's angle, your friends and the people around your support system, there are measures they can take to mitigate. What do I mean? I have a friend who has delivered, whether by cesarean, whether by normal vaginal delivery. During delivery is not the time, or rather immediately she goes home from the hospital, that is not the time to go visit and add the added weight of her hosting meal. Do not visit unless, of course, she really needs the help. So you can send help without you going. And which help am I referring to? If it is financial, chip in. Okay. If it is household chores, please send someone or go in yourself, do everything that needs to be done, leave the house clean for her so that all she has to do is mind the child. My personal favorite is where if a friend of mine has delivered, this is my thing. I usually meal prep. What do I mean? You know that there's no time to mind the baby, change pampers, breastfeed, try and sleep. Baby is not sleeping at night. During the day, you're trying to, usually weekends, I will probably make a very big meal and then I will take it there. So several meals, big meals, portion them out so that that family does not have to think about cooking or meal preparation. It could be as simple as going to the market and shopping for groceries for them. That takes away that extra chore of going to the market and, you know, what are we eating today? What are we cooking? It could also mean just taking the other kids and getting them off her care. Like you can tell her, okay, fine, let me have the other kids for these 3 days. They can be with my kids. You first bond with the other one. I'll return them when you feel ready. You see, that is already a weight taken. There are so many ways. There are so many ways. You can schedule a video call, okay? You can a phone call. So there are many ways. Be creative, and usually we can go around it. The minute we're talking about postpartum depression, postpartum psychosis, there's no room here for leaving it to pass on its own. Here, a psychiatrist has to be brought on board, and maybe the woman has also to get on drugs until such a time that we feel she's quite healed enough to take care of herself and the baby. I will go back to the definition of health. What then is health? Health is a state of complete physical, social, spiritual, psychosocial, and mental wellness, and not merely the absence of disease or malady. And so if we are looking at the physical aspects, then the mental aspect should also be catered for. Good. There are some life-threatening conditions that we cannot just ignore. These ones we have to mention so that once they happen at home, the woman knows to come back immediately. Headaches, okay? Which headaches am I referring to? Especially after cesarean. Usually, if it was spinal, you have what we call a spinal headache. If it was a woman who had pre-eclampsia before, an unrelenting headache could also mean that the pressures may not be well controlled, okay? Eclampsia or seizures, if a woman starts convulsing, there's no room to keep her at home. Bring her back immediately. Hemorrhage. This is a woman who's a week into her puerperal period and she suddenly starts gushing heavy blood. So please bring her back. Let's investigate what is going on. Chest pain that is sudden and constricting. So you may have thrown an emboli and you may have been, you may actually have formed a pulmonary emboli or whatever. So it is good that you check it out immediately possible, okay? If you have a sudden swelling of either one or both limbs, especially on the calf muscles, and they turn red, they turn a bit painful to touch, and you can barely move a limb, we may have formed a clot in our lower limbs. Please come back quickly. Let us manage you appropriately, okay? Good. What are the other issues that probably warrant medical attention, but are not exactly they're not life-threatening, so they're non-life-threatening, okay? If you're having issues peeing, especially, you can pee, but it's a bit painful, so you may want to come and have that checked, okay? Hemorrhoids, yeah, you can pass stool, but it's a bit too difficult. It's difficult to pass the stool. It's also, every time you pass stool, you're bleeding. So you may want to have those checked, okay? If you have incontinence, and incontinence sometimes can happen, especially after a prolonged labor, an obstructed labor, okay? If you have a bit of edema, especially in the vulval region, it's not so much, but it's also not so okay down there. So just come, let us have a look. If you have mastitis or you formed a breast abscess, okay, please come, let us give you proper medication. Let us also advise you on how to go forward with breastfeeding, okay? Vaginal dryness, and then pelvic girdle, okay, or what I was referring to, like inability to move properly, like it's painful to actually move after delivery, among other things, of course, all right? So when do we discharge this woman from the hospital? If it was a normal vaginal delivery, we're talking about 24 to 48 hours. If we're talking about a cesarean delivery, we used to say 96, but now we've moved to 72 hours because there is no added benefit of a prolonged hospital stay, unless, of course, there is need to keep the woman there for longer for monitoring. Okay, so what is the care then that we give you upon discharge? We sensitize you about the changes that you expect to happen. So you're going home, I'll tell you the blood is going to come up to this time. The breasts are going to feel like this. When they're full, you will feel pain like this. This is what you're supposed to do. Here are the danger signs. You come to the hospital when you see bleeding, foul-smelling discharge, engorgement, limb pains, dysuria, all those things. I'll also tell you about the danger signs in the child. Okay, if a child starts convulsing, turns yellow, does not breastfeed well, has fast breathing, etc., etc. So counseling on the danger signs. Okay, when we're discharging you, as I said, we'll mention contraception in passing as you go and think about it. It's like a seed we plant in your head. And then also we have to give you a review date. Usually upon discharge, the review date is like 2 weeks later, even though I don't write it there, and it is rare that I will not write it. You just know, 2 weeks after I've discharged you, please come back. Let me have a look at what is going on, okay? And then also, do we provide the number of the facility? Yes. So sometimes the healthcare provider can give a number, or the facility, the number is usually provided for, so that in case of all these danger signs, the woman is not stranded at home, she can immediately get in touch and maybe be guided forward on what to do, okay? And also when to resume sexual intercourse, we have to mention that at least get to 6 weeks, because sometimes as you discharge, some women may, because of culture and other things, may be forced to engage in sexual activity. The episiotomy is not yet healed. It's just a big mess. So usually we tell you hold off until at least 6 weeks. Let's assess everything. If you're good to go, then we give you the go ahead. Okay. Good. I think that's the end of my presentation. I will open the floor, okay, so that we can ask the questions or maybe additions. Katile, I will invite you back. Hello.
Thank you so much, Dr.
Yeah.
For the elaborate presentation. Allow me go through the inbox.
Okay.
Somebody had some question somewhere. I saw it, so I'm trying to look at it. Was asking about, in your own opinion, Dr. which is the best contraceptive to use? Somebody asked that. That was from Ivina Achian.
Okay. So maybe you can list all the questions and then I'll go through them one by one.
Yes. So I'll also look at the Facebook, the one from Facebook, if there are.
Mm-hmm.
Let me just check, just a minute. Thank you so much for those who are following on Facebook. Unfortunately, I'm not seeing their questions. It's like somebody is just saying, great topic with my best presenter. That is Kania Mario.
Thank you.
Following my all-time favorite, Gynae, right? That is from Jerry Waruguru. Daktari, you are appreciated from Facebook.
Thank you.
Somebody saying, eagerly listening to Dr. Sobra. That is from PK Mukula. I'm not seeing any questions from them. And
There's some in the chat box.
There's a question from Eunice Anwanga saying, thanks a lot, Doc. How long is it recommended for a woman who has miscarried to probably try another pregnancy?
Okay, just before that, there was another question. My sister had a miscarriage almost a month ago. She was cleaned and given meds to prevent further infections, but there's some smelly discharge and minimal cramping. Will there be a problem? So let's go through all the questions one by one, yeah? I'll start with the first one. What is the best contraception? The best contraception is the one that suits you the best. And that is the most honest answer I can give you. As I said, contraception is usually tailored to the woman. I'll give an example. If, for example, you have hypertension, no matter how nicely the pills take you or the injections or the implant, we know that we're not supposed to give you any hormonal contraception. So you see that already takes them out of your radar. Number two, it depends also on your future fertility. A woman coming in at 40 years and having had a vaginal delivery may not necessarily want to wait for so long. She may want to probably get another child and another child like in succession. So for such a woman, I may not necessarily advise on long-term contraception. I'd probably advise on short-term contraception. I'll give another example. If you come in and this is your 10th baby and you tell me that, this is my last baby. So you see, I may offer you a permanent method as opposed to a temporary method. I may want to sort of maybe cut your tubes and tie your tubes so that you don't have another baby. 10 is a bit much. So it's user dependent, and this is, do not even compromise on it. This is not said in passing. If you have passed through my hands, you know that family planning is an entire topic. We sit down, and I usually insist that the man is there so that as we talk, we are discussing, and you're telling me that, I can't do this. Aki, I can't remember to swallow pills. Aki, the injections, they gave me low libido. Aki, no, vaginal. And so we go step by step. What is the expected side effect? What are the good things? How is the coil inserted? I demonstrate. And so you can't say what is the best. Maybe let's say what is the best for you, so that you have to come in and then we patent it to you, okay? So the second question about the lady whose sister had a miscarriage, I'm so sorry about that. And she was given meds and then now she has a smelly discharge. There is what we call PAC, post-abortal care. And post-abortal care is a care we give to a woman who has had a miscarriage, and a miscarriage being a delivery of a fetus before the age of viability, meaning in our setup, before 28 weeks, okay? So it has several arms, but I'll just go through them very briefly. Number one is the sorting out of emergency issues. Emergency issues being, are you bleeding? Do we need to clean you up? Do we need to resuscitate you? Etc., etc. So those are usually done in the hospital, okay? Number two, linkages to the community, because sometimes following a miscarriage, the woman feels a bit isolated. And so you may want to get her into a support group where other women have had miscarriages. Number three, you may also want to sort out the contraception needs of this woman, as I already talked about, so you tailor them to her. And then number four, there is I think I forgot the last bit, but it's economic empowerment or something like that. But after a miscarriage, I've discharged you, I will still give you 2 weeks to come back to the hospital. Why? Because the same processes that happen when you've given birth normally sort of still happen when you've had a miscarriage. Are you still going to bleed little by little as you're home? Yes. Are you still going to, for example, feel a bit of cramping nature as the uterus is going down? Yes. Are you supposed to have a foul-smelling discharge? No. And so probably that would mean she has, or the beginnings of what we call post-abortal sepsis. Now, post-abortal sepsis, the best way to take care of it is probably go back to the hospital. That fluid that is coming out, that is foul-smelling, let them take a sample of it, take it to the lab so that they see what exactly is growing, so that it's causing this, and so that now we can give you the appropriate antibiotic, okay? It is very important because postpartum sepsis actually can be catastrophic. It can cause you to bleed again. It can cause us actually to come back in and take out that uterus in worst case scenarios, what we call a hysterectomy, because you can form what we call a pelvic abscess, usaa kwa utumbo. So do not sit on it. I would advise if there's a foul smelling discharge, you're better off going to the hospital, let them even do a scan, lab works. If they say she's okay, perfect, no harm done. But most likely there is something ongoing. How long after a miscarriage are you advised to try again? This is a catch-22 question, and I will explain myself. I have a patient who, this is a third miscarriage she's had, no single baby taken home. And we know that the reason for miscarriage is X, Y, Z. And her years are also, she's not exactly the youngest. So we are working also against age. So how much time does she have versus someone who just had a random miscarriage or even terminated and is not ready for a child? Those may be very different women, but generally speaking, usually ask you for 2 to 3 months. Why 2 to 3 months? Simply because to allow for the normal physiology to come back to normal. I'll give an example. We know that the pregnancy test remains positive even after you've had a miscarriage for around 4 to 9 weeks. If you didn't know, now you know that if you had a miscarriage today, 2 weeks down the line, should you do a blood pregnancy test, it will still show that you're pregnant, and yet you're not. It's just that the hormones take a while to rise, and then after miscarriage, they also take a while to come down. And so you may want to give these hormones time such that they reach 0, and you're reading a negative, or rather a negative pregnancy test before you attempt again. Number 2, a woman who has miscarried will still continue spotting the normal ile damu chafu ya kuzaa. So I would rather like to think that you maybe go dry before you start having sex again. Also, we know that the first 3 periods are usually not exactly a true depiction of what your periods could be. They could change a little bit. So you may want to give them time so that you see the true picture of your new cycle, that you can even predict when you're fertile or when you're not fertile. So I would say maybe 2 to 3 months, loosely speaking, but there are those who will take longer. There are those who will put on family planning. And then there are those who will definitely ask, please, let's try again almost immediately. We do not have time on our side. Good.
I see some other questions. Allow me read them again. Somebody from, this is, Eunice is saying something. Just allow me just check before. There's some, I have a question that is from Melvin Rayola. How about to go on a wound that you feel it's itching and the size increases? Then Melcy is asking, is it normal to feel pain at the incision area 10 months post-CS? And then Eunice, Esther Uvins is saying, kindly, what did you say about hard pop after delivery? Is there medication to prevent that, or what should one do? Eunice is saying, Katili and Josh, I'm not sure if we had already, or maybe I missed it, or plan to have a session on contraceptives. I would really appreciate if we could. Thanks. I think, Eunice, we had a contraceptive session, and we will share with you the presentations. Then we have Mine Gachawi saying, is it safe for a mother who has delivered through CS do workouts to reduce tummy? And if so, after how long? Jack Ma says it was a nice session and I hope we'll get the slides. Yeah, of course, we'll ask Dr. to present to us some slides and a few things so that we can give to you. I'm looking for the questions. What is the best age range of conceiving? That is from Lavin. Esther says, a friend of mine lost a child due to eclampsia. What could be the cause? Can the condition reoccur again? Are there hopes for her to conceive again? Then Giant is saying, how long does the wound take to heal? after the woman delivers. Then Lavin is saying, Lavin is saying something there. Let me just scroll.
Fistula.
Fistula, yeah. Something about fistula.
Okay.
I'm trying to scroll. What actually about fistula? It's okay.
What causes it, how to prevent it, how to manage it. So I'll start with the first question, which was on the wound, that it's itchy and it's increasing in size. I have a feeling you have what we call a hypertrophic scar or a keloid, and that's usually how it presents. You see, when you're being operated for the first time, when you're having an accident for the first time, you get a skill for the first time, you have no idea how your body heals. And so people heal differently. You've seen women who, upon piercing their ears, big swelling occurs. She will not have predicted that. So how then do you predict, or can you tell that, okay, my wound is not healing well, that the wound is not as flat as it was when it was initially placed? And so I mean the wound, say, after cesarean, and then the edges are starting to rise, and before you know it, it's now a thick mass on where the wound was. And so if the incision
Hello, Doc. Did we miss you?
Can you hear me now?
Yeah, we can hear you.
Okay, so if you already have that history that I had surgery and I formed keloid hypertrophic scar, this time when I'm doing the surgery, then we may have measures to try and mitigate the type of suture we used, how we close the wound. For example, if you form keloids, I will not be so rude and unfeeling as to put nylon suture on you, the sutures that need removal. I may use the smallest, finest suture, okay, like the sutures that plastic surgeons use so that I can close your wound. Number two, we may inject some drugs, and usually these drugs are very many, from methotrexate, triamcinolone. Your doctor will decide on which one. But I have to add that even after doing all this, some people will still go ahead and form a hypertrophic scar or a keloid that you cannot quite totally erase it. You can try and mitigate, but you cannot try and totally prevent it. Genetics are genetics, okay? What causes pain in the wound 10 months past cesarean section? If the wound healing is not happening well, did you form an infection inside? Did you form an abscess, a bit of edema, or hypertrophic scars? So sometimes they are painful in that beyond the itchiness, inside the wound, you feel as if the wound is being stretched and pulled. So that may be the cause. But if that is not the cause, if you do not have a keloid on top of your wound, it is just a painful wound, 10 months is a bit too long. I may want to probably just look inside what is going on in that wound, okay? The other question is, how do we go around hard poop? Can we prevent it? Sometimes, usually I say the best way to go around hard poop is even before delivery. If you're drinking your 3 to 4 liters of water per day, water, sijahesabu chai, supu, juice, sijahesabu lolote, chai, sijui uji, nimehesabu maji peke yake, you probably will not have constipation. Why am I saying this? We know that the baby is breastfeeding, so even the extra water is for the breast milk. So the baby is drawing water from you, you are peeing water from you.
Hey, Doc. Doc, you're muted.
Where did I leave you? Hello?
Yes, now we can hear you.
Where did I leave you?
You were answering the question on fistula.
On poop, not fistula, poop. So
Yes,
if you're
on poop.
drinking your water 4 liters and you're taking your, what are they called? Fiber-rich diet, you're taking your fruits, you're taking your mboga when you're having breakfast, as opposed to say having bread and tea, you're having viazi tamu, nduma with tea. All those are fiber-rich foods. Then you'll probably not struggle much. Mapapai, pears, all those things. Now, if that still is not working and you're still forming hard poop, we can give you some drugs that are stool softeners, glycerin here and there, lactulose. Just talk to your practitioner. I do not want to prescribe right now over the Zoom, but yes, we can go around hard poop. You should not suffer with hard poop, okay? How soon after CS should you start working out and get the flat tummy? And I will also add, maybe some people will ask about corset wearing after cesarean. I usually say 6 weeks. 6 weeks for me marks when the uterus has gone back to its normal size. But we also have to remember that even at 6 weeks, it's not like you're fully healed. It's not like the wounds inside, because you see the wound outside and it has healed and you feel you're okay. But the wounds inside, there are like 5 wounds inside. So have they adequately healed? That is person to person. Again, this thing about wearing corsets, and I will go out here and just speak out boldly about and against them. The size of a tummy is not so much the corset holding it in. It is what you're eating, you're breastfeeding adequately, and all those things. If you're breastfeeding, you're eating healthily, you're drinking your water, the tummy will go, okay? But if you're eating badly, you're not even breastfeeding adequately, you're supplementing on the baby's breast milk, and all those things, no matter how many corsets you wear, the minute you take them off, the stomach will hang out. In terms of exercises, the keyword or the take-home message is listen to your body. And so you ease into things. It took you 9 months to grow this body. It will take you an even longer time for the body to come back to what it was as normal. And so I do not expect at 6 weeks for you to go and start weight training, lifting of weights. You probably start with long walks, swimming, things that are gentler on your core, on your wound, even on your pelvis, even though you don't have a cesarean, by the way, even normal delivery, your core has to heal, the pelvis has to heal. And so I would expect that you start with your Kegels first before you go to major body exercises. Listen to your body. But yes, at 6 weeks, usually we clear you to do most of the things, okay? What is the best age to conceive? During our parents' times, people used to conceive quite early, okay? But I guess with times changing and career and the female emancipation and just basically equal opportunities being afforded to both sexes, we are finding more and more women now turning their attention to career, and there's nothing wrong with that. Actually, if you're to consult with me, I will tell you there is no perfect age to conceive. But even as I say that, keep at the back of your mind that unlike a man, a woman's timelines are very different and they're age dictated. And so the minute we start touching on 30, 35, if truly in your heart of hearts you really want children, then I would say maybe start thinking about it actively, so that we're not at an age where we're almost switching off the hormones and we are now running around looking for kids. So I guess it has to come from a point of honesty. Where are you? What do you want? What truly is in your future? I'm very much okay with you telling me you don't want kids. I can take that. But I'm also not okay with you saying, I don't want kids. Kumbe ndani unataka watoto. Na hutaki kuongea na kujipanga kuhusu watoto. So there's no perfect age. I would say any age that is above legal age and any age before menopause is good enough for you to conceive, okay? Eclampsia. I'm sorry about your sister and the death of her baby. Eclampsia is like the very worst end of a spectrum of the hypertensive diseases in pregnancy. And so you may have this hypertension that is just rearing its head all the way to a woman who comes to you fitting and has probably lost the baby. How do they lose the baby? As you fit,
there is oxygen supply being cut off from the baby. You can have things like an abruptio, the placenta detaching before the baby is born. So most of the time, usually, if a woman comes to you fitting, that baby should be out in 2 hours. Whether the baby is ready for delivery or not, whether premature, alive or dead, that baby should be out in 2 hours. So can it reoccur again? Absolutely. Actually, if you just have hypertension, are there chances that you could have hypertension in the subsequent pregnancy? Yes. If you had eclampsia, which is like the very worst of the spectrum, then chances are very strong that you will get it again in the next pregnancy. So what then do we do to mitigate that? Usually we may have to wait for the pressure to show itself, but there's some drugs like calcium and junior aspirin that you can go on from the very beginning of the pregnancy. This, how they work is, yes, we know you're going to get pressure, but it's just telling the pressure, don't come full force. So yes, you get the pressure, but not the full extent of the spectrum, okay? Are there any hopes to conceive after eclampsia? Absolutely, absolutely. The tubes are untouched, your hormones are very good, everything is okay. The problem is not conception. The problem is the pressure that now affects the pregnancy. So those are two very different things, okay? Good. How soon should the wound heal? And here I'm guessing we're referring to the episiotomy or the Caesarean. Usually I say wound healing has stages, and that is a whole topic by itself. But by 2 weeks, we should have a semblance of a position of the wound. And by 6 weeks, the wound should be totally healed. So whether you were cut down there or you tore down there or it was a Caesarean, say by 6 weeks, we should be done with the outside wound on the skin or on the vulva where you were cut, okay? How can we prevent fistulae and the management of fistulae? Now we have to understand that fistulae can be, most of them, 90% plus, are as a result of poor antenatal care, poor perinatal care, the events surrounding delivery. Here is a woman who clearly, from her bones, her stature, from her size, from everything, the baby she's carrying, we know she would not have pushed. So why did we let her push in the first place? This is a woman who stayed and stayed and stayed and stayed in labor, and the baby was not passing, and the baby's head was pressing against the bladder and the vagina, and eventually it is that head that sort of erodes and creates a hole on the bladder, and so the fistula forms, or on the rectum, and so the poo-poo then keeps flowing. So we can tell that it starts from either antenatal or during the labor and delivery period. Then there are other fistulae that are caused iatrogenically. Iatrogenic means from the hospital. Sometimes during Caesarean, if the doctor is, say, doing things in a rush, or the woman, say, is a previous scar, you have been operated like, say, 4 times before, this is the 5th, that could cause dangers during this Caesarean, and so you may form fistulae. So how then do we treat fistulae? It's surgery. Most of the time it's surgery. You have to go, and not just surgery by any other gyna, you have to go to a urogynecologist who will now do a fistula repair. The good thing about it is there's a lot of noise, a lot of campaigns for fistulae, and even the camps, there's free surgical care for fistulae. And so you should not have to suffer much for it. Yeah.
Thank you, Doc. There's a question again. Somebody's asking, is it clinically allowed to choose the date on which to deliver, as in without waiting for the labor pains, or the date chosen should be after the baby is fully developed? And then there's also another question. Is this another question? This is another question. I don't know, my laptop is misbehaving.
I got my period on the 5th week after delivery. Has my uterus healed completely? So let's start with the first question from Winnie. Is it allowed to choose the date? When is the baby ready for delivery? When we're counting dates and how old your pregnancy is, I hope you realize that we carry the pregnancy to 40 weeks, 40, not 36, not 38, 40. So the EDD is putting in mind 40 weeks. Now, this comes from us calculating from your last period and not when you conceived. It's a lot of, I'm sure we covered this in the earlier sessions. Now, out of the 40 weeks, we consider baby ready at 37 completed weeks. 37 completed weeks, meaning the beginning of the 38th week. And so as an obstetrician, if you ask me to deliver you before the beginning of 38 weeks, the end of 37 weeks, I'll say no, unless of course there's reason to hypertension and all those things. But everything is okay. You're moving okay. Nothing is wrong. You have no diabetes. Things are okay. I will not touch that baby until the day we touch 38 weeks. And so then begs the question, if the labor pain has not started, how then do we start labor other than inducing? So also keep in mind, we've covered this session as well. Keep in mind that induction of labor has its own associated risks. Induction of labor could fail now that you've committed to the process of inducing labor, and now it has failed. You go for a cesarean. So you see, by default, it increases your chances of cesarean section. So what I routinely do with my patients is at around 38 weeks, I offer what we call a membrane sweep. And what is a membrane sweep? It's a gentle reminder to your body, to your cervix that, hey, tumefika mwisho, we're at the very end. You can feel free to bring labor pains. This does not involve me giving you any drugs to start labor. I'm just simply doing a thorough vaginal exam. At that point, I'll ask you, take long walks in the evening, dance a lot of lingala, have a lot of sex, all those things that encourage natural labor to come. And so natural labor will come. But if you do not want natural labor to come, that means the only other alternative is induction of labor, which is not bad. 90% and above, it works. But should it fail, that also poses risks of cesarean section. Now, I had my periods 5 weeks after delivery. Is my uterus well healed? I can't tell. The uterus healing is person to person. And so usually we can assess that by touching the abdomen and has the uterus gone back to its normal place. There are people who have a period quite early. There are people who even go 1.5 years without a period. We are all different. It does not mean that one is wrong, one is right. It's just the way. I think we finished the questions.
Thank you. I will allow everyone to mute if there's still other questions, but I'll allow it to so that others can also raise their hands. Let me just allow. So if there's anybody with other questions, please, you are free to actually mute yourself and then speak about the questions. Meanwhile, let me check from the Facebook if we have any questions. I am not seeing any questions. Anyone who want to mute, or do you feel satisfied of the questions? Leonida Kiriago is saying, very educative session. I've learned a lot. Thank you, Leonida. Thanks, my favorite dog, for taking your time. Be blessed. Well, we are supposed to be ending this session for today, and we are supposed to If you still have any question, we would like you to mute and share with Doc about your question, especially on the topic. And we are sorry that we did this session today. We are going to try as level best to look at being consistent on the days and hours of convening the sessions. We don't take it for granted that you also very flexible to really join today for these discussions. It couldn't be a discussion without participants. So we say thank you so much. And we also say thank you, Dr. Swabra, for the good work. We are happy, we are humbled to be with you today again, just to share with us some of these clinical thematic areas. We appreciate, and we also appreciate everyone joining us from Facebook Live. We appreciate your indulgence. It's very difficult to join meetings over the night, and we are really, really happy that you have joined us and following these discussions. So moving forward, I will request Dr. will do for us a presentation and share with a few materials.
Yes.
The few materials, yeah. We have the Google Classroom. We'll share them through the Google Classroom so that you can always look at them for future reference. And as well, we'll also share the feedback form so that to ensure that we get a feedback form. And then so that when you have any questions from the feedback form, we'll send them back to Dr. and then Dr. writes them back and share back in the Google Classroom. Anybody with any issue? Any burning issue? Okay, I will take that silence as satisfactory for this session. I'm glad today I'm able to learn about postpartum and postnatal family planning. Thank you so much for that session. Without much further ado, okay, Eunice, you muted yourself. I thought you had something to say. It's okay. It's okay. It's okay. So thumbs up. Thank you, Irene Lolo. Thank you so much for that. So allow me. I will now request people. You can leave at your own pleasure. And before you leave, I'll request that. Hey, let us mute for those who can put on their cameras. Wekeni camera. Wekeni camera tuone mkwaje. Hey, imagine tumenyamaza 1 full hour. Then mute, just say hi. Just do hi, hello. Yeah, so that yeah. Thank you. Yeah.
Julie.
At least we can see your faces, but by the way, we are soon ending these sessions, and when we end these sessions, we'll be like, there are people we need to hear their voices. Huh? Yeah. Somebody's network is breaking. Hey, somebody's voice. Where? I see. Oh, these are handsome men and beautiful ladies. Tola, how are you? Hey, somebody's just. Wow, I can see you now so well. Wow, you're a very, very handsome man. Okay, it's nice to always check on participants. You may end up talking to yourself. People might have logged in and are silent. So thanks always for coming in. Yes, Virginia. Atola, you're breaking. Your network is really breaking.
Hey, babu.
Yes, Molly. Oh, okay. So without much further ado, allow me end the meeting and the session today. Let's meet, let's have more conversation on our WhatsApp group. For this week, we'll have the next sessions just as planned as usual, but we'll appreciate the effort that you guys have made in terms of really making, even if there are other inconveniences, but we will try. For the remaining sessions, we'll try forward to look at convening them at the appropriate time, and also looking towards to reach out to speakers as early as possible, so that we may not inconvenience participants. Thank you so much for joining, and have a lovely night and a lovely happy new week. Goodbye, everyone, and good night.